Hello, and welcome to the Harvard Health Publishing webinar, Living Through Crisis, Reclaim Your Health Through the Practice of Storytelling. We're joined today by our friends from the Health Story Collaborative. Our presenters today are Dr. Annie Brewster, Dr. Jonathan Adler, and Kelly Keena. Our presentation will be about 45 minutes and we'll leave 15 minutes for questions and answers. We want this to be an interactive webinar, so just a reminder on how to submit questions. At the bottom of your Zoom screen, there'll be a Q&A function. Presenters will respond to your questions again at the end of the presentation. All attendees will be able to see submitted questions, and you may upvote questions to send them to the top of the queue. There's also the chat tool. We ask that you use the chat tool for technical issues and also to share resources. If you want to view a live transcription, click on that on your Zoom bar. We are recording this webinar, and an archived version of the webinar will be available on health.harvard.edu. And now, to start our webinar, I'm going to hand you to Dr. Annie Brewster.
Hello and welcome everyone. Thank you so much for coming. We're here tonight to talk to you about the healing power of storytelling, and I'm going to share the stage with my colleague John Adler and Kelly Keena. John and I work together at Health Story Collaborative, which is a small nonprofit based in Boston, dedicated to helping patients and their loved ones heal through storytelling, heal by making meaning. We create forums for story sharing within healthcare and aim to work with anyone navigating a health challenge, mostly patients, but also patients' loved ones and healthcare providers as well, because we believe that there is transformative power in storytelling and that can bring us together and heal us all individually and collectively. The title of tonight's talk, Living Through Crisis, applies to our current times. Certainly, these have been strange times. So we're hoping that this can be very practical and that you can take some of what you learn and apply it to your own lives. So I'm going to start. Let me first say that the definition of illness and healing that we have is very broad. And I think that's important to note that it's not just about physical illness. We define illness as any imbalance in spiritual, psychological, or physical well-being, and healing as moving back towards balance. So it's a broad base. Illness, trauma, loss, all of these things apply. So I'm going to start at the beginning, which is by sharing my story. So this passion for this work really came out of my lived experience as both a patient and a provider. So I was diagnosed with MS in 2001 and have been living with it for quite some time. So I really am going to share those journeys with you and how I came to this. It's in large part a response to what I feel is broken in today's healthcare system, having experienced that from both sides. So I'll start with my journey of becoming a doctor. I graduated from medical school in the early 2000s. I was really drawn to medicine by the hope of intimate connection with people, recognizing that that's such a privilege and the promise of really being able to listen to people's stories. I started in psychiatry, but ended up switching over to internal medicine because I really missed taking care of the whole body, the holistic self. But I went into primary care and found it really painful. The system is really set up more like a business than it is anything else, and it's driven by money and efficiency more than relationships. So I worked in a women's health center. We had very brief 15-minute appointments. I felt like I could never really be with people and take care of people the way that I wanted to be. And what made me the saddest, I think, is that the system sort of almost pits patients and providers against each other because we have competing demands on each of us, and no one's happy in the system. So instead of sort of nurturing what's supposed to be a therapeutic alliance, it can feel very strained. So I started turning the wheels then of how can I make this better, and recognize that it was unlikely to happen in the exam room, although I think we can do a job of bringing some awareness about listening into the exam room, but really understanding that we needed some creative solutions outside of the exam room to give people time and space for healing. So at the same time, on sort of a similar track, I was navigating my own illness journey. So when I was an intern, so in the midst of my training, very busy, had a 2-year-old, was actually going through a divorce, so it was a hard time. And I started developing some symptoms, tingling in my legs that climbed up all the way to my abdomen. And I ignored it for as long as I could, but then eventually brought it to the attention of my doctor, had an MRI, had one lesion on my spinal cord, and ended up in a neurologist's office, a very well-known person whose name is on almost every research paper, but didn't have much of a bedside manner. And I was told pretty aggressively that I almost certainly had this diagnosis and I should go on the disease-modifying therapies immediately. I only spent 10 minutes in his presence, and I did not feel seen and heard. And I really couldn't come to terms with it. So I left that office and I really went into a long period of denial for 5 years. And during that time, I really felt a lot of shame, and I felt broken, and I kept it very private. And what I recognized was that it really was sort of an identity crisis of sorts that I was having. And I'd never really thought about this as a doctor, that when we give someone a diagnosis, it really shifts our identity. And for doctors, we're often tasked with coming up with a diagnosis and sort of solving a mystery. And then we come to the answer and we think the story's over. But in fact, what I learned as a patient is that that's when the story is really beginning. And doctors really aren't trained to help people with this process of how do we make sense of big life events that are challenging and how do we integrate them into our lives? And really, it's about integration. So over time, I realized that if I didn't start integrating this, I wouldn't be able to move forward in a healthy way. And stories really helped me. So I started to tell my story more and recognize that it had power to help others. And I felt less shame when I spoke my story out loud and sort of stepped into myself. And then I also started collecting stories of patients in 2010, working a lot with a public radio station in Boston, thinking I can create a library of stories so that people who are in the early stages of illness or any stage can listen to true stories, not just media sound bites, but true stories. And I started doing this work and learned through experience that it was really healing to create this space for story sharing, both for the storyteller and for the listener. I was very lucky. We formed a nonprofit in 2013. That's when we became Health Story Collaborative. But I was very lucky just prior to that to meet Jonathan Adler, who happens to be a researcher who specializes in the health benefits of storytelling. So John has been from the outset the chief academic officer of Health Story Collaborative, and he brings so much expertise. And I'm going to turn it over to him now so that he can share some of that with you.
Thanks so much, Annie. Yeah, it's such a treat to get to work with Annie. And part of my role at Health Story Collaborative is really to take the scholarly literature from the social science of narrative and inform our programs with it. So as we turn our attention to the research piece of this talk, we wanted to pause for a moment to ask this big question: why focus on stories in the first place? So the social scientific literature offers us many answers to this question, and I'm going to give you a brief introduction to 5 of them. So first, if we think about sort of the grand sweep of evolutionary theory, there's good reason to foreground narrative. So scholars have referred to narrative as the human adaptation. This is the tool that we as a species have evolved for navigating our social niche. So beavers build dams and snails extrude shells and spiders spin webs and bowerbirds build bowers, but humans tell stories. This is the tool that we use for navigating the social configuration that we live in as a species. And it turns out that storytelling is actually a really effective, efficient tool for navigating our social niche, which is much more complex than that of a spider or a snail. So at the grand theoretical level, narrative seems to answer this question. Narrative is sort of a uniquely human characteristic. But then if we go way to the other end and just go from the grand sweep of evolution down to just the pragmatic, mundane contours of our lives, telling stories is also just the thing that we do all the time. So some of my colleagues have demonstrated that 90% of emotional experiences are recounted to someone else within a few days of their occurrence. There's one study where they asked people to nominate what was the most memorable thing that happened to you today. So not the grand highs and lows of our lives, but what happened to you today. 2/3 of people in that study said that they had already told someone else the story of that experience by the end of the day. So storytelling is what we do, right? We convert our experience into stories in order to hold on to them. Now, it turns out that the brain is also sort of wired in this way. So we often talk about the most basic psychological process as the translation of sensation into perception. So sensation is like the wavelengths of light hitting your retina, and perception is the meaning that your brain makes of that. And even at this most basic perceptual level, we're weaving stories. So here's a little example. I assume you have no trouble reading these 2 lines of text. But if you look closely, the B and the 13 are identical, right? So exactly the same wavelengths of light are hitting your retina, but because they're framed in these little beginning, middle, and ends, our brain has no trouble imbuing them with completely different meaning. Okay, and here's another example, right? I assume you have no trouble seeing the white triangle. Well, again, even though we know it's not really there, if we extrapolate that back up to the ambiguity of our lived experience, it's no wonder it's the same process. So again, even at the most basic level, our brains are weaving little stories about the sensations that our sensory inputs receive and making meaning of them. At Health Story Collaborative, as well as in my research program, we really like to also elevate the ethical imperative. A lot of psychological research is very top down, where the experts come up with their theory and then they go test it. But narrative scholarship tends to be very bottom up, where we just listen to people's stories and then try to make sense of what's going on across them. And so from an ethical foundation, we feel really good about the approach to the research. And then again, if none of these perspectives have persuaded you, then I'll just offer you the hard-headed data. This is a paper that some colleagues and I wrote several years ago now, but we pulled together every study at the time that had compared the relationship between narrative variables and other kinds of variables that psychologists are interested in. So things like our demographics or our dispositional personality traits. We looked at every study that had compared those things in predicting our psychological well-being. And over again, we find that the stories that we tell about our lives are stronger predictors of our mental health than these other kinds of variables. So even if you just look at the data say narrative is important. So I hope I've offered you a variety of compelling reasons that focusing on storytelling is absolutely vital. So now let me connect our storytelling work to psychological well-being. So in the psychological world, we tend to think about psychological well-being as having 2 broad domains. They have somewhat cumbersome names because they come from Aristotle, but I will explain them. So the first we call hedonic, and the second domain is called eudaimonic. So hedonic really means it feels good. And eudaimonic means it feels meaningful. We know that these 2 domains of psychological well-being are fairly unrelated. And again, if you think about experiences in your daily life, you could think about things that feel good but aren't especially meaningful, things that feel meaningful but don't feel especially good, things that feel high in both or low in both. So the question is, how do we get from my story, the story that I'm telling about my life, to these 2 domains of psychological well-being? And what the scholarly literature seems to suggest is that it is the themes in our stories, not the content. We find over and over that the content of people's stories is actually fairly unstable, meaning people tell different kinds of stories about their lives over time. But the themes over and over again have robust relationships with well-being. So I'm going to walk you through a few of these themes. These themes really form some of the bedrock of the work that we do at Health Story Collaborative. And there are many more than the ones I'm going to introduce to you today, but I'm going to give you just a little smattering. My colleagues and I developed sort of a framework for understanding all the themes that have been researched. So I'll give you these 4 categories of themes and then a few examples in each. So the first set of themes are motivational themes. All stories are about a character trying to do something. And when we think about the sort of the signature motivational themes, we call them agency and communion. So agency is a quality of the self. How do you portray the main character in your story, i.e. you? Are you in the driver's seat of your life, or are you more batted around at the whims of external forces? And again, these are themes in stories, right? No one is actually completely in control of their lives, but the way that you tell the story of your life actually really matters. And higher levels of agency tend to go along with psychological well-being. The companion to agency is communion, a sense of connection, reciprocal relationships. And again, we find that higher levels of communion are associated with better well-being. So the next category of themes are affective themes, or themes about the emotions in our stories. And just as you would expect, you know, sad stories aren't great for us and happy stories are good for us. But what the research finds is that it's actually the way we sequence the emotion in our stories that tends to matter the most for our well-being. And so the sort of signature pair of themes I want to tell you about, we call redemption and contamination. So in redemption stories, things that start bad and good, and in contamination stories, things that start good and bad. Again, all lives have good and bad in them. So this is really about where you make connections between events, where you parse the chapter breaks of your life. And we find over and over again that redemption is very, very positively associated with psychological well-being, and contamination is quite bad for our psychological well-being. Again, themes in stories, not the objective reality of our lives, but the themes in the stories that we tell really matter. The next set of themes are really about how we go about integrating our experiences and making meaning. And here the pair is called assimilative and accommodative processing. So most of what we do most of the time is assimilative, right? Our lives go along, new things happen, we just assimilate those new experiences into the story that we've been telling about our lives. But every once in a while, something happens that really doesn't fit with the story that we've been telling. It calls that story into question, or we just sort of get sick of living out the story that we've been telling about our lives. And then the story itself needs to change to accommodate this new thing. Okay, so those are sort of two modes of meaning making: assimilation and accommodation. And then the last category of things we look at in people's stories are really sort of the structural ways in which people put their stories together. And here we mostly look at the overall coherence of people's stories. And yes, obviously, if a story doesn't have a certain level of coherence, then it's not actually even a story, it's just a jumble of words. But when we think about narrative coherence, we're talking more about, can I logically follow the flow of this story? We're looking at all the different threads and how they're integrated. We're looking at the experience of the audience, and are they understanding what this story is about? So that is a smattering of themes. And when I hand it back to Annie, she's going to talk to you about how we use some of these themes in our actual day-to-day work at Health Story Collaborative. I just want to remind you that there are lots more than the ones that I've pulled out today. So when we think about the relationship between narrative themes and psychological well-being, we can remember there are these two domains of psychological well-being: hedonic and eudaimonic. Feels good, it feels meaningful. And we find that there are two pathways to these themes. So stories that are highly coherent, that feature our agency, our communion, that have redemption sequences, those tend to feel good. But stories that get deep into exploration and sort of the active search for meaning in the face of hard things, those tend to feel meaningful. So in our work, of course, we want to support both kinds of well-being. There are scholars who write about the combination of hedonic and eudaimonic well-being as the good life. And so in our work at Health Story Collaborative, we're really attending to both pathways to psychological well-being. Sometimes feeling good is not an option, but even in those instances, we can still pursue meaning. And pursuing feeling good in the absence of it feeling meaningful might not go as deep as we wish that it would. So we are often attending to this whole suite of themes as we do this work. And now let me turn it over to Annie to tell you a little bit more about how we actually do this work.
Thank you, John. So we've been talking about sort of the why of storytelling, and now we're going to talk a little bit about the how. But I just want to say, from my point of view as a patient, what is inspiring to me is something that John always says, which we remember that we are both the main characters of our stories and the narrators of our stories, so that we actually play an active role in deciding how we tell it. And to me, that gave me a lot of, made me feel empowered as a person going through something challenging. That we can't always change what happens to us, but we can change the meaning we make out of what happens to us. And our stories are never stuck. They're in motion. They're constantly in motion. So for me, there's hope in that. So I'm going to tell you a little bit about one of our primary programs called Healing Story Sessions to really best show you how we use this research in an applied way. And I hope that you can then think about how you might apply it to your own stories. So Healing Story Sessions are live storytelling events, and we work with people in advance for pretty intensively to write a draft, or we've done it with people just in spoken word if they are not able to read and write, but it's writing, and you don't have to be a writer. Anyone can do this. We have prompts in our narrative guide that are grounded in the research, and we help people to write an initial draft, and then we edit and we edit and we edit together in that process. So I'm going to just go through sort of the steps and the process. In the initial drafting, first of all, I'll say that our narrative guide is sort of structured as turning point stories. So we think of things like illness or trauma or loss as turning point moments, recognizing that not everything fits this model. And we always say to people, you can follow the prompts or not. But we really try to pull for sort of the before self, the moment of what's happening, and then the after self. But when people start writing, we tell them just, don't think about sharing this with anyone at the beginning. Think about it as just for yourselves. Don't worry if it hangs together as coherent. The most important thing that we're pushing for is sort of specific sensory snapshot moments. So we ask a lot of questions, like pick a scene that sort of represents that period of your life, and why is that important to you, and why does it represent that moment? The more sensory detail, the better. But we don't want people at the beginning to hold themselves back and feel like they have to have sort of a coherent finished piece. Write private. The next step then in editing is really working to nudge towards health, we say, to pull for these themes. So we want to help people notice where those themes already exist in their stories, and then develop them further, and then find new agency, for instance, or new communion. But we're asking questions in a probing way to help people explore that. We don't necessarily name the themes. We don't say we want more agency here. We ask probing questions that help people sort of go deeper and find these things. So I'll give you some examples. So if we're talking about agency, for instance, we might say, in navigating this illness, put in trauma, loss, whatever, what personal strengths have helped you get through? So how did you do it? And we encourage people to name it. We ask a lot of questions that pull for agency, but that's just one example. And then when we're talking about communion, we really encourage people to think about who was there for them on that journey, and to sort of name those people and connect with that. And then going on to the next themes, let's see, we have redemption. So we ask, obviously, has anything good come out of your illness? How have your priorities and passions changed since you've had this illness? Now, I will say that Don always says our culture is very obsessed with redemption. We really like redemptive stories, and not everything is redemptive. However, I'd argue that there's always redemptive threads in our stories. So we can always, even if we're at the end of our lives, find redemption, even if we have an illness with no cure. Maybe it's the deepening of relationships or getting new perspective, but there are always redemptive threads. Same with all of these themes. No story is going to have all agency. There's going to be some moments where there's not agency, but we're going to try to develop them. And we're going to see as many of these themes as possible in one story. And then, in terms of accommodative processing, so meaning making, we're going to ask, what have you learned? How has your life changed? How have you changed in ways that you wouldn't have if you hadn't had this experience? So really probing for the meaning. And then with the coherence, what is the right chronology of the story? What should be put in? What should be left out? And also, again, the more specific details, the more coherent the story is going to be. So that's sort of a very quick overview. But above all else, we're sort of pushing for a very authentic story. For it to be therapeutic and beneficial, it has to be true to yourself based on your experience. And then specificity, 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 just really bringing it to life, showing us those moments that are sensory. What did you smell, feel, taste, hear? Bring us into that scene with you. And sort of that brings me then to sort of the sharing part. So preparing to share is part of our process. John has a background in theater, so he's very good at working with people to help them prepare, to think about the medium, right? So this is not theater, this is not comedy, this is not slam poetry. It's actually very intimate, it's authentic, it's very personal. And we're not trying to make it, we don't hide the fact that it's performative. Some people can hold notes, and but it is a very intimate experience. And John also works with them on pace and tone and emphasis to try and help the audience connect with the story. Now, people don't have to share. There's still a lot of therapeutic benefit in just going through this process of engaging with your own story. But we believe that there is an added element to sharing stories in community. So there's research that we don't have time to get into that does support the health benefits of listening to stories. So being on the receiving end is also good for us, both for our physical health and our mental health. But it also just connects people. It's sort of a tonic for isolation. And we know there's a huge isolation problem in our country. And it magnifies the benefits. So it ripples outwards. And I would say for the story sharer, that itself is agency, to feel like you're giving back your story in a way that helps. And there's magic that can happen when you have a story that's shared in community. So pre-pandemic, we've done a lot of these events in person, but it also can apply online, but it's easier when you're all in the same room. That there's magic. The person up there sharing is being vulnerable and open and real, and that gives everyone else in the room permission to be open too. And I think it's really a gift, and it can create really powerful connections between people and dialogue. I also like to think about storytelling as a relational act. So no story ever exists in a vacuum. We are always in a web of stories. So when I tell you my story, how you react might change how I tell that story next time, maybe just a little, but it probably will change it some. And you hearing my story may change your story, and so on. So we're in this sort of dance of telling each other stories. So I'm going to say a bit now about how at Health Story Collaborative, we put this research into action. Obviously, I just told you about the Healing Story Sessions program, but we have a lot of different models. And so we're going to just briefly run through those. So the Healing Story Sessions, we've done these in a lot of different venues. As I said, it's a lot of prep. Usually we work closely with people for 4 weeks or so before the events. We have 2 storytellers usually at each event, 2 patients sometimes a patient and a provider, where they tell their stories side by side as a way to sort of show the humanity of both patients and providers and try to heal that relationship. We've done them in private homes, we've done them in the hospital, we've done them in public venues, so they can be done in all sorts of ways. Another project we have going is called the Opioid Project, Changing Perceptions Through Art and Storytelling. And this is about using art and storytelling for social change. So working with people who've been touched by the opioid epidemic, people who've lost a loved one, people in recovery, first responders, to create art and then share audio stories and then create these multimedia art shows with the goal of decreasing stigma, sort of showing the humanity of people who may have substance use disorder, that they're human beings, not just quote unquote addicts, and to really sort of move the needle and ultimately prevent opioid related deaths. And then also we have a little kiosk that's at Mass General called the Sharing Clinic that's stocked with 200 plus story clips that people can search by theme or by diagnosis and listen. And really the goal there is to change the culture of the hospital, to sort of create a collective conversation. And I think, there's so many people in the hospital going through similar things, and we often sit in waiting rooms and don't look at each other. So this is a way to sort of create more of a collective environment within the hospital. And now John will tell you about a few more programs, and then we're going to get to hear a story.
Yeah, thanks, Annie. So, right, in addition to this suite of things, as Annie said, I have a theater background, and we collected a pair of stories that we were so moved by that we actually decided to turn them into a 2-character play called Resurfacing that dramatized these 2 stories. We worked with a theater troupe in producing that play. So this was another sort of artistic interpretation of people's stories, a different kind of form for us to share this work. We do a fair amount of writing for other outlets. So we've written for the Boston NPR station's Common Health blog. We've done some writing for Caring Bridge, which is a big international nonprofit that allows patients to share their stories. So we're always trying to get trying to elevate the role of patient storytelling. Annie and I co-teach a course at Harvard Medical School for advanced students that really focuses them in on how to listen to patient stories. The hope is to really get them grounded in patients' lived experiences before they head off into their residencies to further specialize. And then, as Annie said, we do a bunch of big public events, so webinars like this. We had a collaboration before the pandemic with City Space, which is a big public venue run by WBUR, one of the Boston NPR stations. And we love any opportunity like this to take the work out into the world and help people understand and really receive people's stories. It's one of the reasons that we're so delighted to share Kelly's story with you today as sort of an example of how our Healing Story Sessions program works. So let me hand it to Annie to introduce Kelly, and then lucky you, you'll all get to hear Kelly's story.
Yes, so we're going to have a taste of a healing story session tonight. We're really lucky to have Kelly with us. It's going to be shorter than our usual. Often we'll let people have 15 minutes or so for their story. We have 2 storytellers, and then we have discussion. For tonight, we're going to get to hear more like a chapter or an excerpt from Kelly, but we're really lucky to have her. So Kelly comes to us from Colorado. She's an educator herself, an environmental educator, and she is living with cystic fibrosis. And this happens to be Cystic Fibrosis Awareness Month. So that fit neatly. And we're so fortunate to have Kelly. So I'm going to give her the stage, and then we're going to come back together after we hear Kelly.
Excellent. Thank you very much. I'm going to just jump right in. I'm just really grateful to be here. It's here. I got the email sometime during the night. I'd been tested so many times that I no longer felt dread when I opened it, but there it was. A lot of words and an oddly puffy, bright red exclamation point next to the word positive in all caps, positive. Despite staying in my house for more than 18 months, except for doses of nature hiking and paddling on the mountain lakes nearby, I knew COVID for me was a when and not an if. So I immediately did 3 things. I called my husband. I texted my nurse, who replied with encouragement, "You're going to be okay." And then I made a handwritten spreadsheet. I wrote down all of our usernames and password for banks, credit cards, 401ks, online bill payments, and instructions on how to access everything on my computer that only lived in my head. My first thought, when I died, I wanted my husband to be able to access our finances. COVID comes with a heavy threat for many and for me. I live with the chronic disease cystic fibrosis. This recessive genetic disease mutation was passed down silently for generations in my family. The dysfunction is at the cellular level, affecting my sodium chloride channels. So CF patients struggle with mucus that is sticky, the consistency of silly putty, and really difficult to clear. We create these cozy little moist places in our lungs where viruses, fungi, bacteria all thrive. They often become a part of us, this parasitic relationship with our body's most basic need, breathing. An overabundance of mucus also gums up our pancreas, bowels, and reproductive parts. While the physical ailments are numerous, I am actually more curious about the mental symptoms of a life with chronic disease. We dance between well and not well, this fragile line that our bodies sweep across until they don't anymore. CF is considered a disease that is chronic and life-shortening. There is no end in sight, but the end is always looming. CF is also an invisible illness, not easily detected visually by people who don't know me. Being invisible means not being seen. And being seen is what creates connection and belonging. And connection is the antidote for loneliness. And loneliness may be more lethal than the disease itself. Lying in bed with COVID, terrified, one page scrawled in my journal with 3 words: do not disappear. COVID didn't kill me, but that list of passwords is coming in very handy as my memory is newly slippery. For 4 months, I felt like my body was on a simmer, not burning, but a new sensation of heat, like too much wasabi in my lungs and simmering my nerves. My heart is also off. My pulse jumps from 80 to 160 to 120 to 65 as I lay in bed. My heart also aches with anger at the world for railing against the most basic precautions like masks and vaccines, and fear that I'll never recover. And I won't lie, a little bit of self-pity. That's disorienting because my normal is quite the opposite. I don't languish in pity. And COVID made me sick, which felt normal, but I felt scared, which was this brand new emotional invader. Part of the loneliness of CF comes from the challenge for a fully able-bodied person to really comprehend the experience. Chronic translates simply to again and again and again. Get sick, get well-ish, get your shit together, and get back out there. But back out there is complicated. In June of 2020, I stood at my kitchen door for a solid 5 minutes, one hand on the doorknob, car keys in the other, mask already on my face like a shield, a long white cotton scarf wrapped around my neck 3 times in June. I stood there trying to work up courage to open the door and get in my car and drive to the clinic. I needed to see my doctor, but he was out there. I was flooded with fear and uncertainty. The pandemic was the war I'd been preparing for. I know lockdown and isolation. Anytime CF patients get run down or an infection, we get 2 weeks in the hospital, followed by 2 to 4 weeks of lying in bed, recovering as the world carries on. I know how to tuck into my home. I know how to order groceries, wipe them down, do video calls, and navigate human spaces outside, touching nothing. Social distancing, a term invented by CF. We know 6 feet. And now there's going out. That is harder. It's the hardest. I pick up my phone, this digital window into the human world, and the headlines read, "Federal judge ends mask mandates on transportation." A judge, not a physician. Headlines are micro traumas. This is the mental toll. On Twitter, flight attendants are filmed handing out champagne to celebrate this very sudden change, some mid-flight. I travel in service of my job. My second flight after the pandemic started was 2 days after the judge, not doctor, revealed faces. I was flying to speak at a conference, trying to get back out there. At the airport, I stand in line 6 feet behind a tall man wearing his off-the-shelf relaxed business casual attire, face bare. He exchanges small talk with a woman next to him. "It's nice to see your face," he says. "Oh, yes," she says. "I feel conflicted, but I see I'm in good company." As she speaks, she gestures to the crowd around us, all unmasked, and then she turns to me, and our eyes lock, me behind my N95. "Oh," she says, "oh, sorry. I mean, maybe we're not all in good company." Then she starts stammering on about feeling conflicted and something about a moral issue, but mandates, she never believed in those mandates. I stayed steady, deep breaths, silent. Casual business guy looks back at me and says, "It's time to take them off." I hold fast, I say nothing. I try to make myself feel big because I feel meek, a feeling I'm not good at feeling, invisible. This phrase "back to normal" with images of people frolicking in sunny meadows, bare faces, large crowds. What you don't see in these prolific images are those of us huddled in tucked away places, masked and exhausted. And you didn't see us before the pandemic either. There was never really a normal for us, but the gift of chronic illness is the ability to adapt and survive. This is the war we've been training for. I turn off the news and I turn to the natural world. I listen for the robin's sweet songs at dawn and the constant chatter of the finches. I go for walks. I paddle on the lakes. I meditate. I write. I stick to my routines that normalize my day, and I seek out the people who do see me, my husband, my daughter, my mom, and my best friend. And I allow them to help me find levity and beauty in spite of the world, in addition to the world. My daily calendar app helps me organize my day as a checklist, which I love. It gives me this sort of sense of false sense of control. The app is pre-programmed with one daily task: wake up. Every morning I do just that. I wake up and I get to check that box. This is the gift of chronic illness, a keen sense of daily gratitude and wonder that every day we get to wake up and hear the birds. That's my normal, even in this uncertain world.
Oh, thank you so much, Kelly. If we were all together in the same room, we would pause. Instead, please feel free to use the chat if you want to put some comments to Kelly. She'll be able to see them there. But I'm going to give us a moment to pause before we dive back into things, because I just want to give that an opportunity to soak in. So thank you. All right, so not all of the storytellers that we work with are as articulate as Kelly. As Annie said, we've worked with all types of folks, including folks who can't write their stories. And Kelly's approach is a sophisticated one that really weaves together a lot of the themes that we've talked about. Now, Kelly doesn't, we didn't sit down and say, Kelly, you need a little more agency or whatever. But as Annie and I worked with Kelly, we were listening for these things, and you can see hints of them, right? So I think that daily checkbox that says wake up and then you check it off, that's finding some agency in a period of time that is very disempowering for us. That's a brilliant workaround. There's lots of communion in Kelly's story. She talks about her family, but she also talks about the community of other folks who have cystic fibrosis. She talks about them as a we, really knitting her own story together with other folks in that who have a similar experience. Kelly's story ends with the theme of redemption. She talks about the gift of chronic illness, which is not how it probably feels all the time. And it's not a perspective that everyone is able to bring to their illness experience. But construing it as having some gifts is a way of giving it some redemption. And of course, Kelly's story is suffused with accommodative processing, right? Even in the face of real intense challenges, there's a sense of striving for meaning, trying to understand this experience and ultimately get the eudaimonic well-being benefits that come from that search for meaning. So we've loved working with Kelly, and we are so proud of this little piece of a story that she's produced to share with you. Again, as Annie said, we tried to just do a little excerpt of this as opposed to the longer format that we would do if this whole webinar were just a healing story session, instead of trying to share some of our model at Health Story Collaborative too. So thank you, Kelly. Kelly will also be joining us for the Q&A in just a few minutes. So please feel free to ask her questions as well. The last thing we wanted to say is that very recently, just this spring, Annie has published a book. Oops, sorry, my screen didn't advance. A book called The Healing Power of Storytelling. It really outlines a lot of the approach that we've given you a taste of in this webinar today. So if you're interested in learning more, this book is available for purchase now, and it's an opportunity to learn in a little more depth. So with that being said, we really, despite the webinar format, we really do want to engage with you. So we've left these last 15 minutes to take your questions. Kathy is going to play MC of the questions, and she's been able to moderate the Q&A button. But please don't hesitate to add other questions in the Q&A, right? So feel free to keep using the chat if you want to list comments for Kelly about her story, but otherwise put questions into the Q&A, and Kathy's gonna hand them off to the three of us, including Kelly, please. So we really look forward to taking your questions. Welcome back, Kathy.
Thank you, Jonathan, Annie, and Kelly. Wow, what a great session. You've answered one of the questions already about where can I find more resources. So thank you for giving some information about Annie's book. We have a really interesting question. Someone just learned that their doctor has been diagnosed with Parkinson's and he's not doing well. So how to show him or her support, offer compassion without making them feel weird about boundaries? What should they do?
I think I'll take a stab at that. I think I personally would recommend just being direct and open and honest and just expressing your well wishes and your thoughts. I do think that boundaries are important, but I think sometimes they go too far in medicine because, and that's part of why we run these patient provider healing story sessions, to create a safe space where we can hear the human side of the provider and hear the human side of the patient. And these are patient provider that have been in a therapeutic relationship but haven't heard each other's stories until then. And they work with different narrative guides, one for the provider and one for the patient. So I think we're sort of, in some ways, working to open up those boundaries a little bit, never wanting to burden patients. I say as a provider, I never want to burden patients with my story, but I have become more willing to share a little bit about my journey when it feels like it would actually be helpful to somebody. So flipping that around, I think as a provider, I would be really happy if someone said, I learned that you had an illness and I send my best. I don't think that can go wrong.
Great. An interesting one. What do you think about, do men tell heroic stories and women tell caring stories? What's your thoughts on that one?
I can take a crack at it from the research perspective. You know, it's interesting. Like Annie said, our individual stories exist within the web of stories in our culture. So our personal stories are always in dialogue with what in the field we call the master narratives that are out there in our culture. And so, of course, there are hugely gendered master narratives that people need to engage with in a certain way, either to reproduce or to repudiate, but they're inescapable. That being said, when we look at these other kinds of themes, the ones that we've talked about today, we just don't see big gender differences. So it's not that men's stories are all about agency and women's stories are all about communion. We tend to see both agency and communion in stories of men and women and non-binary people as well. In fact, some of the early writing about agency and communion referred to them as the superordinate themes of life stories, that all stories are about a character trying to do something in relationship to other characters. So we don't see hugely gendered ways in which the themes that we've talked about today pan out. And I guess that's hopefully reassuring.
I think this next one builds on that. There's a group that developed a program for veterans where they read Homer's Iliad. For those who have a difficulty telling their story, are there ways in which they can relate to the difficulty of others, I'm guessing in a classic story, and through that process develop a greater awareness of their own story?
Again, I can start. Feel free to jump in, anyone else. Absolutely. I mean, as Annie said really nicely, we deeply believe in the power of other people's stories to impact our lives. There's a line of research on that's called the function of fiction. And the basic question is, why as a species are we drawn to stories that we know are not true? And yet, how have we all coped with the pandemic with binge watching TV and movies and other forms of a lot of fictional stories? And the answer is fictional stories are deeply instructive. They're moving. They help us understand our own story through other people's lenses. A big part of the joy of fiction is experiencing parts of the world or experiences in the world that you don't have a firsthand experience with. And we find pretty powerful impacts on the audiences at our live events. I assume many of you were as moved as we were by Kelly's story just now. So yeah, even if you're not ready to tell your own story, engaging with other people's stories is an incredibly powerful experience.
Absolutely.
Whether they're truthful or fictional. Go ahead, sorry.
Yeah, I'll just add also that there are, different ways of telling your story, and there's always a narrative element, but we've worked, as I said, the Opioid Project uses art as one modality. So people may be more comfortable expressing things in different ways. And so there are, it doesn't have to be in writing. Though again, I would encourage people not to feel like they think of themselves not as a writer and are therefore limited by that, because we can all do it.
There's some questions about the class that you take that teach at Harvard Medical School, and is this required? Maybe you can speak a little bit more about this as part of medical education.
Sure, I'll start and John, jump in. It is not required. It's an elective for third and fourth year. So it's like a 1-month intensive. And we have a pretty small group because we work with each student works with a patient to help them tell their stories. And then it culminates in a storytelling event. It should be part of the required curriculum. I think it's very interesting to me as someone who's been to medical school that I knew nothing about this social science research on storytelling before I met John. And it's so relevant to what I do every day with patients to just keep these principles in my mind as I engage with people. So I think it should be required, but it's not at this point.
Mm-hmm.
I wanted to jump in really quickly. I meant to kick off the Q&A by asking Kelly to just say a little bit about your experience working with us. And you had an opportunity to engage with one of our Harvard Medical students as well. So I don't know if you want to share anything. You certainly don't have to, but I thought it would be nice to hear your experience of telling your story in this process.
No, sure, I would love to. I always say that I thought I started writing these stories for other people, and I discovered that the writing actually has been for myself. And I think you both taught me that, and the process of this has taught me that there, this healing, I think of chronic disease as chronic healing, that the illness part is hard. It's the mental toll of that space between one illness and the next that is that sort of get back out there idea. And this story telling and now story sharing with people who I don't know has been pretty profound for me. And I loved watching the presentation now that I have worked with you, and I see something different in it every single time. And I go, oh yeah, that, yes, that. So it just, I feel like I just get to get deeper and deeper into the power of this work as I do this.
Thanks, Kelly. We're so glad to get to work with you. And yeah, for those of you here in our model, we don't usually then sit down with the storyteller and give them a lecture about what we were doing. We try to keep it in a really relational space. So Kelly was a very willing participant in this experiment that we're doing here. And we're so glad to have your story to be a part of this. Kathy, you can take us back to the questions and the Q&A.
Sure. They're really rolling in. What about for people who have lost relationships? I think of grief. So, is this practice for that as well? And are there any adaptations?
I'd say it's very applicable. It's like I said at the beginning, our definition of illness and healing is very broad. Certainly, loss counts as part of that. It is a big turning point moment, and it is something that changes our identity and that we have to integrate or create sort of a new self story moving forward and go through that process. So I think it's absolutely applicable.
Yeah. Someone shared they were recently diagnosed with a mental illness and wondering how they can get past maybe the stigma in order to share their story.
Yeah, I mean, that's such a problem with stigma is terrible for mental illness in particular. I'd say the more people that share, that's a way to fight against stigma but of course you have to do so in a safe, supportive audience. So I think speaking out, but you have to feel ready to do that. And, I will say I've shared a lot in spaces where they're public and, let's say something that is posted online. And even if 99% of comments are positive, you're going to get a few that are negative and hurtful. So you have to be ready for that. So I think you have to personally feel like you're in a space. Like when I started telling my story, I had enough internal reserve to say, I can do this and I can handle the feedback. But I think it's especially vulnerable with mental illness. But I really encourage people to speak out about it, because I think the more we do that, we sort of move the needle on the master narratives that exist if we have more people speaking out and sharing that. And that is social change, and it's important. And I think it's healing.
Agree. Any advice on sharing stories when the emotion still feels raw? Is it a sign that you're not ready to share? And someone commented, Kelly was so eloquent, but how do you get to that place? How do you get to where it feels easy to share?
I'll start and then you jump in, John.
No, I think then Kelly should jump in.
Yeah, or Kelly. Yeah, I mean, I think you have to know yourself well enough to know, is this stepping into this vulnerability? Is this the right time, right? If you're in the midst of a really big struggle, you're not going to have enough distance to have made sense of it yet. We certainly have had sessions where they're quite emotional. So people don't always, hold it together, and that's part of the process. But I think, yeah, you have to feel yourself ready and not necessarily be in the midst of a crisis. But Kelly, I'd love to hear your thoughts.
Yeah, I think I totally agree. I think, I've been just dumping out emotions into notebooks for years and years, and getting from the point of even letting my closest family in on these stories is very, very new to me. I was diagnosed 25 years ago, and some people in my family are just now realizing what CF is. Aside from my husband and my daughter who lived with me, these are very big revelations for people that I did have to dig pretty deep and go, okay, I'm ready for them to get to see this part of my life that exists behind my closed front door. For me, COVID was the time that I felt like it kind of spurred this need in me for people to understand the chronic, especially invisible chronic disease, because of, I think there was an incident where people stormed a Capitol with guns to rail against masks. And I was like, okay, wait. And that's when I started moving a lot of my writing from my notebooks to a blog, and then had the fortune of meeting John and Annie, and moved and worked with a Harvard med student in this process. And that was the first time that even my family had heard me say these things out loud. So it is a process, and you do have to be ready for it. And I would say, John asked me after and by the way, this isn't easy to get to this kind of piece. There's so much support built into this process, and so much editing, and in just the best ways. And during the rehearsal, John asked me at the end, how did that feel? And it was like, oh yeah, that was a little bit raw, and so even in the moment, I've written it, I've read it a million times. And when I say it out loud, it's very, very different than just putting it into writing. And it is something that I wasn't ready for, but I'm really glad I've experienced, because it's also making me aware of some other emotion that I've sort of stuffed down in living with this disease, is that, so yeah, I think
the only thing I want, thanks Kelly. The only thing I want to add as just a closing thought on this is that this is only one way of sharing your story, right? That if things are still feeling really raw and unprocessed, then that might suggest that you would benefit from some private support, getting a therapist, someone you can tell your story to in a truly private and supportive way, just to support you through the rawness.
Well, there's been a lot of questions about resources, how to get in touch. So I am going to share my screen for a moment with some resources that people can follow up with if they have questions. So let me see here. First of all, thank you for attending this webinar. There's such engagement, such involvement in the story Kelly shared. We have a survey following the webinar. If you could please complete that and let us know what else you'd like to learn in future webinars. You can connect with Annie, Jonathan, Kelly via the Health Story Collaborative, the info@healthstorycollaborative.org. And this archive, again, this webinar will be archived on health.harvard.edu. So check out our website for the latest news on health and wellness. I just want to thank our presenters again. What a dynamic presentation. We learned a lot. Again, I think we could have 3 webinars on this subject and still have a lot of questions. So thank you, Annie, Jonathan, Kelly. Thank you for answering the questions, and thank you also to the audience for all your comments and questions. Again, follow up with info@healthstorycollaborative.org. And thank you. Have a good evening.
Thank you, everyone.
Thank you.